thank you for the invitation to speak and share some perspectives on using trusted research environments. So I co-lead the electronic health record group in the Bristol Medical School with Rachel Denholm and Jonathan Stern. And we are a group that established in the pandemic to do some of the COVID response work using trusted research environments. Over the past 5 years, we've had access to numerous trusted research environments, including SAIL, Open Safely, the NHS England Secure Data Environment, and the UK LLC. And my colleague Rachel is working with the Southwest Secure Data Environment as well. So my talk's going to be in 3 parts. I won't linger too much on the first one because I think Simon covered a lot of it, but a bit about the national linked electronic health records that we have in England. Then I want to show you some of the work that we've been able to do using these resources to investigate the consequences of COVID-19. And then finally, as the title suggested, some perspectives on actually using the trusted research environments. So, as you may know, electronic medical records first appeared in the UK way back in the 1980s, but they weren't adopted nationally. There were several different GP system providers that started the electronic health records. And this means that for a long time, well, and still to this day, there is quite fragmented primary care electronic medical records. It wasn't until the early 2000s that we actually saw the electronic medical records widely adopted in primary care. But even as late as 2019, we have limited information in hospitals in England. So only 10% of NHS trusts claim to have fully digitised hospital records. And we see this playing out in the pandemic. It reflects the data that we have access to. And more recently, the government have made this statement about analog to digital and trying to improve some of this situation. So in England, as I just alluded to, there's several different primary care providers and they each hold their data separately. So the 2 main ones are TPP and EMIS. And then the rest of the data is largely collected from administrative or cost recovery data sets. So the primary care data is for the purposes of patient care, but something like hospital episode statistics, which covers the hospitals in England, is actually used as a cost redemption data set. And then the Office of National Statistics holds some of the other data, such as the index of multiple deprivation and the death registry. And we have some disease-specific data sets in England. So important to our work, the COVID-19 vaccination data, but also the UK renal registry. There's registries for cancer, cardiovascular disease, lots of different things. So in the different trusted research environments we work in, we have access to different parts of this picture. So Simon covered the rise of secure data environments very nicely, but as he alluded to, there's been several reports that kind of pushed the data access models that we have towards using trusted research environments instead of sending out data sets. And this came to head in 2022, where the Department of Health and Social Care declared that NHS health data should be shared in trusted research environments. And that means we've moved from this model where we've been sending out lots and lots of copies of the data sets that don't necessarily get updated when things change and we don't have a good understanding of where these data sets end up, to this model in the secure data environment where we flip the script. So instead of data going to people, people just go to the data and it stays where it belongs. So as of today, there are 3 main ways to access the English primary care records for research, and then they link out to those other data sets that I mentioned. So the longest running, as in we were using it before the pandemic, is the Clinical Practice Research Data Link, the CPRD. And that currently has around 18 million people in, and you can get complete access to their records, so everything that's in the primary care record. During the pandemic, 2 new trusted research environments emerged, and they were Open Safely and what is called the NHS England Secure Data Environment. And these were set up under the emergency copy notice for COVID. So their permissions are for COVID-19 research only. And the way that they were established was slightly different. So Open Safely worked in very close collaboration with some of the GP providers. So they have complete access to the whole record. And they worked with TPP and EMIS. So you've got effectively two GP system providers there that provide coverage of most of, but not quite all of England. And then in the NHS England Secure Data Environment, they use a data set called GDPR, which is a pandemic planning data set. It is restricted in terms of the codes that it includes. So it focuses on things that they thought would be relevant at the start of the pandemic. So it has a particular focus on respiratory and cardiovascular type coding. So it's a restricted record, but they were able to get it for almost the whole population. They pulled from all of those different GP system providers. So we, as of today, have a lot of access to primary care records and linked electronic medical records for COVID research in England, much more than we ever had before the pandemic. I'm going to particularly focus on Open Safely today, and that's because the research I'm going to share with you was conducted in Open Safely. So Open Safely operates a bit differently to the other trusted research environments we've been talking about today, where you never see the actual data that you're working with. So it has this built-in process that supports reproducibility, where you develop and write your code using dummy data. So you can do that locally on your computer, and then you upload the code to GitHub, and that, using Docker containers, is run on the real data that is kept on the servers of the GP system providers, so the data never leaves them. And then the aggregated results are sent back to a server where approved people can log on, view the results, determine whether they're safe to be released, and if they're safe, they get sent out back to the researcher. So this has really changed the way that we think about conducting this science, because we are never seeing the data, we're writing our code slightly differently and thinking about problems in a slightly different way than we have been. So now I'm going to tell you a bit about how we've used Open Safely to investigate the consequences of COVID-19. So the aims of this research, which was funded by some of the national core studies that Patrick Valence set up at the start of the pandemic, was to examine associations of diagnosed COVID-19 with subsequent clinical events. And we did that at a couple of key time periods during the pandemic. And because we now have access to this national data that's very large, we can start to drill down on things a bit more than perhaps we could have previously. So we're able to look at particular subgroups that might be of interest. So for this particular project, we focused on COVID-19 severity, so whether you were hospitalized with your COVID, age, sex, ethnicity, prior history of some outcomes, and whether you'd had COVID-19 before for the later time periods where that was possible. And that's these kind of things only start to be possible when you get to these really big data sets, because previously it's been very hard, for example, to do work on certain ethnicities because they're not very well represented in the smaller data sets that we did have access to prior to the pandemic. So the pandemic was complicated in terms of comparing people because lots of different things were happening at different times. So there were different COVID-19 variants and different people had different vaccination statuses at different points. So we split this up for the purposes of our analysis into 3 cohorts. So we looked in a pre-vaccination cohort, so that was everyone that was available to us from the start of the pandemic through to the end of 2021. Because of the time that they were exposed to COVID, they likely had the wild type or alpha variant, so the very first people to get COVID in the country, and they were unlikely to be vaccinated at the point that they had that COVID. Then we, later in the pandemic, during the Delta variant era, from the 1st of June 2021 through to the end of 2021, we looked at people according to whether they were vaccinated or unvaccinated. So these people, because of that timing, were likely exposed to the Delta variant, and then they were either required to have 2 vaccinations, so their full primary course of vaccination to be considered vaccinated, or were eligible but had received no vaccinations to be considered unvaccinated. And in these 3 cohorts, we looked at a range of different outcomes, and part of the work that we did in Open Safely was to make a very reusable set of code that could be applied to these different disease outcomes. So we looked at each of these separately, but we were using a lot of the same code to do that because we'd written it in a generalizable way. And today I'm going to focus on cardiovascular, mental health, and diabetes because they are approved for public sharing. So for those of you that are interested in statistical analysis, it's a time to first event, so it was a Cox analysis. We had to fit using a calendar timescale because of the differences in the amount of COVID available at different times, the amount of COVID that was occurring at different times during the pandemic. And we stratified by region, again, because there were large variations across the country. We report adjusted hazard ratios in key time periods post-COVID and in the 3 cohorts. So all of the comparisons we're making are people who had COVID versus before or without COVID-19. So the other problem of working with large national data is just the quantity of data that you have access to. So our data set is made up of something that looks a bit like that. So the majority of the people in our data set have had neither COVID nor the outcome of interest. But there are then the people that have experienced the exposure, in this case COVID, or experienced the outcome we're looking at, and the people that we're really interested in that have had both. And the data in the trusted research environments is too big for us to read into R or Stata or whatever your preferred software is all at one time, because there's up to 55 million people. And so we take a sampling approach to get around that. So we take everyone that experienced the outcome or the exposure and an up to 20% sample of people who experienced neither the exposure or the outcome. And then we use inverse probability weighting to reweight that up to the full population and robust standard errors to account for the fact that we've done that. So this is one of the things that you have to think about differently when it's not specific to all trusted research environments, but where you get to a position where you're working with lots and lots of data that you can't read in. So these are the kind of plots that we get out from the analyses that we've been doing. Grid lines have disappeared for some reason. But on the far left here, we have arterial thrombotic events, an example of cardiovascular outcome. In the middle, depression, and on the right-hand side, type 2 diabetes. Along the x-axis, we're looking at how many weeks it was since you had your COVID. And then on the y-axis, we have the hazard ratio, 95% confidence interval for having the relevant outcome. You can see we generally see the same pattern across disease areas where we get really high initial hazard ratios and then they drop off with time since COVID, but they never quite get back down to 1. So there's an elevated risk for the people who had COVID at the earliest point in the pandemic for up to a year after they had their COVID. The differences between the cohorts are very interesting as well. So we generally see that people that were vaccinated when they had their COVID fared better than people that were unvaccinated, either because the vaccines weren't available, shown in gold, the pre-vaccination cohort, or because they were eligible and chose not to be vaccinated. So that's the unvaccinated cohort shown in blue. In the interest of time, I'm not going to show you any of the subgroup results, but if you are interested in any of these results, we have published on cardiovascular, mental health, and diabetes, and all of the details can be found in these papers. Okay, so for the last bit, I just want to spend some time reflecting on actually using trusted research environments and what's changed. And a couple of things have happened at the same time, and not all of these are necessarily based on the fact that we've moved to trusted research environments, but the kind of change of direction of how we're accessing data has prompted people to rethink how how we're working with it. So one thing, the big change for us, and this is, I think, the most separate from it being a move towards trusted research environments, is the data has got much bigger. And that was really a result of the pandemic, that there was a need to look nationally at things rather than in the small data sets that we've had. Trusted research environments do facilitate bigger data in some ways, because we're not keeping so many copies of things in so many places. So there is an opportunity there to house bigger data. The biggest thing personally has been we're working now in much bigger teams than we were before. So working in a trusted research environment, it involves a lot of people being involved. So in the case of something like the NHS England secure data environment, we needed people to work on the data cleaning and setup, people to work on the analysis. There's output checkers to get stuff out of the environment, as well as the clinical expertise that we're drawing on, as well as those people that are coding and doing the statistics. So we're now working in much bigger teams than we ever were before, where you could do a project, for example, in the CPRD with kind of yourself and a couple of others. We're now working mostly across institutions, actually, in really big teams. The move to trusted research environments has also prompted more open science, and this is particularly clear in Open Safely, where there's that built-in reproducibility, but actually the access to the NHS England secure data environment, as well as Open Safely, require you to post your code that you've used in the environment. So just by putting that requirement in as part of data access, we're getting more open about what we're doing with this data. And the use of national data has led to a bit more impact for our studies, because we're reporting the national statistics after COVID for cardiovascular disease, for example. So I think that's in part related to the bigger teams as well, that just everything seems to have got bigger. So to summarize, the pandemic has been a major shift in terms of the national linked electronic health records available in England. It's a really exciting time to be working with the electronic health records. And they can be used to do very impactful research and useful research, such as investigating the consequences of COVID-19. We're hoping in the next couple of weeks to months that the permissions will be broadened for non-COVID work, so that we can start to reap these benefits in other disease areas that we haven't been able to study during the past 5 years. And in terms of the perspectives of using trusted research environments, there has been a real change in the way, what my day-to-day now looks very different than it did before the pandemic, in terms of the research I'm doing, because I'm working in bigger teams with more people across institutions, and doubling down on kind of that open science and working together, which has been, I think, a real improvement. The science that was done was conducted by the people on this slide, so thank you to all of them. If you want to hear a bit more about the Electronic Health Record Group, we recently got a website, so please check that out. And this work was supported by the National Core Studies, so thank you to them. Thank you for listening.